Today we are pleasure to welcome Dr. Rajendra Gautam, MSc, MLT, PhD, a very special guest from the Nepal. The today's webinar on diagnostic challenges of scrub typhus in South Asian countries. It's going to be very wonderful session for us, and we are looking forward to having you, sir, again as our guest. Thank you, sir. The keynote address by Miss Muskan Jain, student of BSMLT second year. Please over to Muskan Jain.
Good afternoon, sir. Am I
Muskan
audible?
Jain, have you there?
Good morning, sir. Good afternoon, sir. Am I audible?
Yes, Muskan, please proceed.
So, very warm good afternoon to you all. I would like to start my session by a beautiful quote that is, be less curious about people and more curious about ideas, said by Mary.
You are audible.
Totally.
Yes, yes, good afternoon, and respected Dean sir have already joined. Okay, please, sir.
Okay, sir. Am I audible now?
Yes.
Okay. I would like to start my session by a beautiful quote that be less curious about people and more curious about ideas, said by Marie Curie, totally admired by contradict. To that, today I'm more curious about both the person who is having amazing bio and far curious about what he is going to share with us. A very warm good afternoon once and all. My name is Muskan Jain, second year student, welcomes you all on the behalf of School of Medical Allied Science. Today, as we all know, we are gathered here for a webinar topic that is diagnostic challenge of scrub typhus in South Asian countries. First of all, let me tell you, webinar is a very effective way to pass on the great grand information. Though in this pandemic where we are lacking our schedule for studies, and very big appreciation to those who conduct this webinar and give their precious time to us. Such an amazing personality is now today present among us. Please let me introduce Dr. Rajendra Gautam, sir. He will help us to know globally for value-based education, research, activity, and innovation. Now I would like to enlighten you with his amazing bio. Rajendra Gautam sir is an MSc in MLT, PhD in an academician, researcher, and a microbiologist currently working at Nepal. He has his post-graduation degree in MSc MLT Microbiology and Immunology from Manipal University. He has worked for more than 8 years as a coordinator of BSc MLT and clinical microbiology program at Chitwan Medical College, Chitwan, Nepal. He has published more than 20 research articles in reputed journals, presented his paper at national and international conferences. Currently, he is serving as CEO, International Path Lab, Managing Director, Chitwan Fertility Center, and microbiologist at Maternity Hospital, Kathmandu, Nepal. Now, I would like to hand over to Mr. Rajendra Gautam, sir, to please enlighten us with your grateful knowledge.
Dr. Vamsi.
Yes, sir.
Dr. Vamsi, good morning.
Good morning, sir. Good afternoon, sir.
Very good afternoon. I, Professor P.K. Sharma, Dean Medical Allied Sciences and Pro Vice Chancellor, welcome Dr. Rajendra Gautam to this beautiful topic and very interesting topic of today's webinar. My one request is, Dr. Vamsi and Madam Muskan, kindly allow your second year students and third year also. Let everybody should join. Right,
Sure,
share
sir.
them in that group.
Sure,
The reason
sir.
being
Sure.
is that when I was going through the details of Dr. Rajendra Gautam, I was very much surprised that Dr. Rajendra Gautam has done the PG from a very prestigious institute. Then he has completed his research also. He has completed his doctorate also. Further, Dr. Rajendra Gautam has done work in the medical college, right? And he has become an entrepreneur also, the CEO of a very beautiful and very prestigious fertility center and medical testing center. So when such a person is there that who was starting from the job to the entrepreneurship side, we must call all our youngsters. They should learn from Dr. Rajendra Gautam that how the journey goes. And I was watching his face also on the video. He's very charming, very beautiful, and he's not looking that he is a CEO. He's very smart. So Dr. Rajendra Gautam, we welcome you, sir, on this platform. And we are feeling it that you will naturally motivate our students also that yes, you can also change the scenario. And nowadays, as the government demands that we should go only for the Indian make, so our students can also learn from you. And I will request every student, see, the all detailed and all this topic will be taught by your Dr. Vamsi, Dr. Yashwant, every faculty is there. Please discuss with Dr. Rajendra Gautam how to go for this path, how to learn this. Friends, you might not be knowing, all students are young. I was called at AIMS and I was the guest speaker over there and the chief guest at AIMS also in this medical lab technology department. And to my surprise, people are MSc MLT, but they have not done PhD. I'm proud of Dr. Rajendra Gautam. I'm meeting the first person who is the doctorate in the medical lab technology sciences. So I want that Dr. Rajendra Gautam, I personally request him to kindly motivate my students not to stop at only BSc MLT or MSc MLT. Rather, they should go for the doctorate also, because we are not getting the qualified faculty. This time we have started MSc MLT also, and I am in the search of doctorate people. I will request Dr. Rajendra Gautam also, if he can help us to identify some good faculty member who is having PhD in medical lab technology. And I request my students also that after completing this, you will find that in the maximum hospitals and maximum organizations, now they are starting PG also, and we are not able to get the faculty. So without taking much of your time, I am thankful to Ms. Muskan Jain and Dr. Vamsi and Dr. Yashwant and all these staff members for inviting me and giving this opportunity. But I want Dr. Vamsi that every student should interact. I want to
Yes,
see
sir.
on video also that every student should interact with Dr. Rajendra Gautam. So once again, I welcome Dr. Rajendra Gautam. With these, thanks a lot.
Sure,
Thank
sir.
you.
Thank you very much, sir. Thank you very much for your wonderful words. Yes, over to Muskan.
So, as we address our doctor, I would like to call him and hand over him to with all our to please share his words with us.
Yes, sir. Yes, sir. You are audible, sir. Rajendra, sir. Now it is audible, sir. Rajendra, sir, you are audible now. Yes, sir. You are audible, sir. Please.
Good morning, all of you.
Yes, sir. Yes, sir.
Thank you so much for giving me the opportunity to speak on this topic. I'd like to thank the Dean sir, and also I'd like to thank my friend and all the staffs over there of this good going university. Actually, this we are during this pandemic of COVID-19, and in during this pandemic, we have got the opportunity to learn and to talk something new in our own field. So today, I'm just going to speak about the diagnostic challenges of scrub typhus in South Asian countries. And myself, Rajendra Gautam, I have done my master's from the Manipal University, and then done my PhD in scrub typhus from the Institute of Medicine, Kathmandu, Nepal. So we start now. Introduction of this scrub typhus. This is the mite-borne acute febrile infectious illness that is caused by the Orencia Susugamusi. And this disease was actually uh, started in 1899 from Japan, and this is at first seen in the Susugamusi Triangle. And now current reports, it shows the beyond the limit of Susugamusi Triangle, that is the places other than the Susugamusi Triangle, and this mortality rate is 0 to 30% in untreated cases, and sometimes there might be up to 50%, and there are around 1 million cases per year. So this is caused by the obligate intracellular gram-negative bacterium, and this exists as short rod or cocobacilli, and its length is 1.2 to 3 micrometer in diameter, and this transmit due to bite of the larval stachygos of the trombiculid mite, that is the Leptotrombidium delens, inhabiting the rodent. So these mites are mainly found in the rodent, and due to bite of the chigor mite, human beings are accidentally get the disease. So this is the Susugamusi Triangle, and in this Susugamusi Triangle, Nepal, India, and all the South Asian countries and other Southeast Asian countries fall under this Susugamusi Triangle. And this triangle, before we used to call it as Susugamusi Triangle, but now this is not only confined with this triangle. Now we can see it in Peru, that is South America, in Chile also, and then after in the France, European countries, and also in the African countries, Senegal. So what we can say now is this is seen beyond the limits of the Susugamusi Triangle, and that is worldwide in distribution. So this bacteria falls under the phylum of alpha proteobacteria. Then order is Rickettsiales, family Rickettsi, tribe Rickettsi, and genus Orencia. And there are two genus, one is Rickettsia and another one is Orencia. Before this Orencia was also kept under the Rickettsia itself, and so in some of the world literatures we know this as a Rickettsia Susugamusi, and now it is under the Orencia, and that comes under the uh, genus of Orencia, not the Rickettsia, and Orencia Susugamusi. And there is another one species also beyond this Orencia Susugamusi, that is the Orencia chuto. Then life cycle of this Orencia Susugamusi. First of all, human beings, they are the accidental host. They can get this organism, this bacteria, through the bite of trombiculid mite, that is larva or chigger. and this life cycle will continue in the rodent, that is mice, larva form, which is present in the mice, and they will develop to the nymph. Both the nymph and adult are free living in the environment, and due to the transovarian transmission, they may release the egg, and these released eggs, they will develop into the trombiculid mite or larva of the seagulls, and these larvae they mainly fill on the rodent, and their life cycle will continue, and we human being are the accidental host, and we get the disease from the bite of the trombiculid mite present in the rodent. So major antigenic type are the different serotypes of Orencia susugamusi. There are carp-like serotypes most prevalent worldwide, that is 39.5%, and these are found throughout the endemic area. And JZ related, they are present 10.3% JZV, and they are the Gilliam type in Japan based on the serological activity, and JG 8.1 percentage. TA763 strains, they are first identified in Thailand, but they are now present in China, Taiwan, India, Australia, and Kato 6.3 percentage throughout the endemic region. KTB 5.2% also present throughout the endemic region. Siatama 5.5%, similar to cap-like strains, and found in Japan and also Korea and China. And Kuroki, these are the fully sequenced boring strain, and Kawasaki found in Japan and China, Gilliam found in the Myanmar, and Shimokoshi found in the Japan. So the main strains which are present in Nepal and India are the carp-like serotype strain, and their prevalent worldwide is also higher among other strains. And next, it comes the pathogenesis. So infected mite, that is the principal vector to the host. They spread through the lymphatics and multiply in the regional lymph node, and then they spread by the bloodstream. So due to bite of the infected mite, the organism enters inside our body. Then they will multiply in the regional lymph node, and they will spread through the bloodstream infection, and the final target site is the endothelial cell of the most common organ, including the skin, liver, heart, brain, meninges, kidney, and lungs. And after the addition to the endothelial cell, their addition helps by the outer membrane protein, that is OMPA and OMPB, present in the bacterial cell surface. And following the addition, the organism are phagocytes. And if they remain inside their intracellular location, they multiply in the cytoplasm, and then they bud from the cell, and these organisms, they does not contain the bacular membrane, so they grow freely in the cytoplasm of the infected cell. The bacterium is able to attach the microtubule assembly inside the human cell for their movement, and there might be the antibody opsonized bacterium, which may be able to escape the phagosome but cannot effectively move on microtubules. As a result, overall infective is or overall infection is decreased. And these Orencia susugamusi, they may be disseminated into the multiple organs through the endothelial cells and macrophages, resulting in the development of multi-organ failure. And these multi-organ failure, mainly the brain, kidney, and liver, may lead to the fatal complication in the human beings. And when we observe the clinical feature, this is mild disease in some patient, whereas other patient may suffer from more severe illness if there are any other underlying causes like diabetes, and then after blood pressure and other organic other organ disorder. and their mortality rate is 0 to 30%. And human being first disease symptoms are quite variable, ranging from mild to fatal illness. And the first clinical sign and symptoms is the fever, and after the incubation period of around 6 to 21 days, mean 10 days, first sign of disease in the patient is seen, and that is the vesicular lesion at the site of mite feeding, and then which later becomes the scar, and then also there seems the regional lymphadenopathy. So this scar is painless and seen at the site of the mite bite, mainly in the groin, axilla, genitalia, and neck. Sometimes there might be seen the multiple scar if the mite bites in the multiple places in the human body. Otherwise, mostly up to 95% of the cases, there is only a single scar. So we can see here in this figure, these are the scars, this one and this one. An early clinical manifestation of the scrub typhus, they begin with regional lymphadenopathy, and after that that is followed by the fever, headache, myalgia, cough, and rashes. And this disease may get complicated by the adult respiratory distress syndrome. Sometimes there might be congestive heart failure, acute hepatic failure, acute renal failure, disseminated intravascular coagulation, meningitis, diarrhea, gastrointestinal bleeding, meningoencephalitis, myocarditis, and multi-organ failures. So that means almost all the system of our body may be infected or may be destroyed by the bacteria when that is not treated in the initial stage. So clinical characteristic in the scrub typhus IgM ELISA positive patient. This was published during my PhD research, and this fever is 100% because it is the acute febrile illness condition. Then after nausea, headache, shortness of breath, abdominal pain, tachypnea, ventilator support requiring the person around 52 percentage, sorry, around 14.5 percentage. Then there is in the jaundice, hypertension, seizure, COPD, diabetes, hypotension, and scar. These are the clinical characteristic present in the scrub typhus patients. And next are the hematological parameter. In this hematological parameter, there might be seen the anemia, that is low level of hemoglobin in 45 percentage cases. There is decreased leukocyte count, or sometimes there might be leukocytosis, or the patient may have the normal leukocyte count also. And when most of the cases, when we do the platelet count, then there is in the thrombocytopenia, decrease in the total platelet count. And in the biochemical parameters, there might be increase in the urea and creatinine level, that is due to dysfunction of the kidneys. Then after, there can be seen dysfunction in the liver enzyme, so bilirubin is increased, and mostly the liver enzymes AST, ALT, ALP are also increased, and protein and albumin are also increased, or there is dysfunction or disbalance in the hepatic enzymes. Then next it comes the risk factors, these factors that may contribute to the increased incidence of the scrub typhus. There might be due to increased outdoor activities performed by the urban inhabitant. Then after, there might be cause of the rapid urbanization of the societies, people living in houses with shrubs and bushes, changes in an ecological environment, then traveler in area with potential exposure to the rodent and mites, like camping, trekking, and people staying in the temporary shelter. And those people who are residing in the rural areas with their house near to the grassland, and those who are working in the field has the higher odds of acquiring the scrub typhus. And seroprevalence and outbreak studies have identified various occupational and behavior risk factors, which include being a farmer, particularly on dry cultivated land, working in vegetable fields, bundling waste straw, then living at the edge of village, sitting on grass while taking breaks, and having close contact with rats for the exposure to the causative organism. And there is seen the seasonal variation of this disease scrub typhus. So this seasonal occurrence of scrub typhus varies with the climate in different countries. The period of epidemic is influenced by the activities of the infected mite. It occurs more frequently during the rainy season. And however, the outbreak have also been reported in the cooler season in a country like India, where areas such as forest clearing, riverbank, and grassy region provide optimum condition for the infected mites to thrive. And the reason after the rainy season might be due to the rodent and mice population who live uh, uh, in the ground, and they will remain inside the holes for their habitat, and during the rainy season, due to the more volume of the water, they try to escape from those areas, and they will enter inside the human being's house. So many studies have described increased number of chiggers during the period of increased rainfall. Therefore, scrub typhus outbreak are often associated with monsoon and rainy season, or the period of heavy rain. In the temperate region, their cases are correlated more with the temperature variation within than with the rainfall. So there is evidence of climate change that might be affecting the temporal occurrence and number of scrub typhus cases in some area. So peak incidence of scrub typhus outbreak in our neighboring country in India and China and Bhutan were observed during the highest rainfall. So this is the monthly distribution of scrub typhus positive cases, percentage of total, and in this we have seen the maximum number of cases during the month July, and this was very low number in the month of February and March. So this shows that during the rainy season or during the monsoon season, the total number of scrub typhus positive cases will start to rise, and subsequently they will fall down and they will reach up to zero level during the month of February and March. And this scrub typhus cases in India. In India, the first probable case of scrub typhus was reported from India-Burma border in 1943. After the initial frequent outbreak during the Second World War, the incidence decreased greatly with the advent of antibiotics and widespread use of the insecticide. In India, the disease has been reported from almost all the states like Himachal Pradesh, Tamil Nadu, Karnataka, Kerala, Rajasthan, Manipur, Pondicherry, Sikkim, Punjab, Andhra Pradesh, Haryana, Jammu, Uttarakhand, and West Bengal. So it is reported as a emerging and re-emerging disease of recent years in India. Okay, then now we moved on to the diagnostic test of scrub typhus. And before this, just want to tell you that the method which was commonly employed during the initial stage, that is the well Felix test, is the earliest one, and still that is used commonly used test for diagnosing the scrub typhus, but it reportedly lacks both the sensitivity and specificity. So it is better to discontinue test this test while diagnosing the scrub typhus. Now also we can find the well Felix test kit, which is commercial kit available in the market, but this is now mm, not used that much, and that now we can get the rapid diagnostic test kits, so we can use them. Other serological tests after this well Felix are rapid diagnostic test kit, enzyme linked immunosorbent assay, indirect immunofluorescence, and indirect immunoperoxidase assay. So indirect immunofluorescence assay is the current gold standard test for the diagnosis of scrub typhus. And culture of these organisms is also possible, but it requires the expertise and dedicated laboratory facilities. And molecular techniques such as polymerase chain reaction are very useful for diagnosis of the disease at the early stage, but the rate of positivity by PCR decreases greatly with the treatment. So while considering the diagnostic test, we say indirect immunofluorescence assay is a gold standard, and in case of the scrub typhus, polymerase chain reaction and other ELISA and PCR. Even PCR is a sensitive and specific test, but also for the diagnosis it cannot be used. Only may be used for the research purpose, but it is better to use the indirect immunofluorescence assay. So specimens, we use serum for biochemical analysis and also for the serological test. Then EDTA blood for the hematological parameters. Punch biopsy of scar samples might be used for the polymerase chain reaction. And mainly for the molecular analysis, we can use the buffy code sample, which is separated from the lavender color coded vacuum, that is the EDTA tube, and stored in the 20% glycerol at minus 80 degrees centigrade. Then DNA might be extracted from the buffy code sample using the any DNA extraction kit, but here as an example given the high yield DNA mini kit YGB300, developed by the Real Genomics Taipei, Taiwan. We use this test kit for the extraction of DNA. And the first and very easy test which can be commonly used in our laboratory is the rapid diagnostic kit, that is the lateral flow immunochromatography rapid test. This number of RDT kit for the scrub typhus, both IgG and IgM antibodies are commercially available. Result can be read within 15 to 20 minutes. So in the scrub typhus IgG test, it consists of the recombinant protein R56 or REC56 as a capture reagent and gold label protein A as a detecting reagent. And for in case of the scrub typhus IgM test, we use the monoclonal antibody to human IgM as a capture reagent, and colloidal gold conjugated recombinant antigen R56 as a detecting reagent. And this also depends on the kit which are commercially available. Some of the kits they may use the strains like 763. Also they may use these antigens from the different strains of the bacteria, and here they use the recombinant protein. And this is the reporting of the scrub typhus. And in the first kit we can see kit 1, that is control band shows here but no test band, so it is the negative. Kit 2 is both control and test are showing in both IgG and IgM positive. And kit 3 positive IgM only, then in positive kit 4 positive IgG only, and the kit 5, that is the invalid test, there is no band in the control and test. So this rapid diagnostic test kit, we can uh, read their result within 10 to 15 minutes, and their sensitivity depending on the manufacturer, they say it as 99% sensitive, and 100% specific during nowadays. And next one is the enzyme-linked immunosorbent assay, that is ELISA. This ELISA is a flexible alternative to the indirect fluorescent assay IFA technique. Mm, The antigen used in the well was a recombinant 56 kilodalton type specific antigen, and in cases of infection with the Orinchia Susugamusi, a significant IgM antibody titer is observed at the end of first week, whereas IgG antibodies appear at the end of the second week. The observance of these ELISA is read under 450 nanometer, and these reports results are recorded as positive or negative. And while doing the ELISA, it is better to find the local cutoff titer in the healthy population, because it might be different in the places endemic areas, or it might be different in the state level, or it might be different in the country level. When we are taking the ELISA test as a reference test, at first we need to find the seroprevalence rate, or we need to do the seroprevalence study in our area, and then after we find the uh, seroprevalence rate of the healthy population, and then after only we can compare this with the disease population. So it is better to use the seroprevalence rate of the particular area. The result of Scrub Typhus IgM ELISA test we can just see as here negative control, positive test, and negative test. And this IgM ELISA was first developed in 1979, and at that time they used to say it was shown to have similar sensitivity and specificity to the immunofluorescence assay. And recent studies have demonstrated a performance with the sensitivities in the range of 85 to 93% and specificities between 94 and 97%. The diagnostic cutoff value suggested is more than 0.50. That is the manufacturer cutoff. We can take that in our particular study area. Here is given one example. In the northern Thailand, determine the OD cutoff value between 0.3 to 0.6 depending on the reference comparator. And recent study from the Bangladesh, they determined the cutoff value to be in between 0.75 to 1.25. Then next it comes the indirect immunofluorescence assay. This is the gold standard test for the serological detection of Scrub typhus antibodies, and this is also called the reference standard. This test is more sensitive and specific, but it required the qualified staff as well as more expensive method, and samples can be tested fresh without delay. And biopsy specimen of the skin with a rash around the lesion and also the petechial lesions are most important samples which might be used for the indirect immunofluorescence assay. And initial screening of the IFA, here we can see the initial screening is done with three groups, that is spotted fever group, typhus group, and scrub typhus group antigens. And glass slide are specially designed glass slide used for the immunofluorescence assay. And initially we screen for the spotted fever group, typhus group, and Scrub typhus group antigen. If in the initial screening, if it comes positive, this STG antigen, that is the Scrub typhus group antigen, then after only we go for the serial dilution of the different serotypes of this Orencia Susugamusi. In the second stage, what we do? First, we do the initial screening by immunofluorescence assay, that is spotted fever group, typhus group, and scrub typhus group. And why, if there is positive scrub typhus group, then after we can go for the individual serotyping, that is the Orencia susugamusi, Gilliam, CAP, Keto antigen, and Orencia chuto antigens are used for the titration of sera positive in initial screening of the STG antigen, scrub typhus group antigen. So here what we quote is Gilliam, Cato, and chuto strain, and this is the, we keep here as the positive control and here the negative control, and we compare with this with these positive and negative control, this sample number 1, sample number 2. At first we keep diluted 1 is to 128, 1 is to 256, 1 is to 512, 1 is to 1024, and so on. That means it will go on increasing, and we will find the titration. And these four different types of strains, these are the main strains which we use their antigen for the diagnosis of the antibody by the immunofluorescence assay. And these positive results are indicated where fluorescence is evident in serum that has been diluted to 1 is to 128 or greater, and negative results are reported where serum does not fluoresce at a dilution of 1 is to 128. So this is the green fluorescence of Orencia susugamusi observed under the fluorescent microscope. The most important thing what we need to keep in our mind is the dilution of of 1 is to 128 is the minimum dilution, and if that is below this, then after we don't take the reference, or we don't take below 1 is to 128 as positive. And this here also, like the ELISA, we also can do the titration of the human sera of healthy population in the community, and we can find what is the level of antibodies, or what is the level of this titration in this area, in the endemic area, to find the here. So in some places might be 1 is to 256. In some places they have reported 1 is to 512 as a positive. And when we have done, we reported 1 is to 128 as positive. So here is also given the local cutoff should be determined based on the scrub typhus seroprevalence in the healthy individual or the healthy population. Then this better enable the acute infection which can be distinguished from the previous exposure, and which is especially important if testing is performed on only one acute sample. And the variation might be there due to the microscopist who is reading the slide. The microscopist determines the endpoint titer. So inter and intra-operator variability has been demonstrated, and microscopists should undergo the several months of training, or they might be supervised by the more experienced staff member before their results can be considered reliable for this immunofluorescence, because the immunofluorescence for this is directly depend on the observer who is observing, who is reading the slides. So this drawback of the IgM ELISA, however, is the relatively high cost and requirement of the fluorescent microscope and trained personnel. ELISA might be done by all the persons, but in case of these immunofluorescences, the person should be trained enough to give the endpoint titer, otherwise there might be false positive or false negative reporting. And next, the molecular study. And for this molecular study, the most common target of these assays are the genes encoding the 56 kilodalton antigen and 47 kilodalton surface antigen plus the 16 S rRNA and ergo EL genes. We can find the target for this 46 kDa, 47 kDa, 16 srRNA or ergoel genes. So during the early stage of the disease, PCR has been demonstrated to be more sensitive than the IFA. Acute phase or the day first of the development of the fever, when we do PCR, we can find the good result. And when we do it after 7 days, then antibody will start to appear in our body, and there is a decrease in the antigen. That means the PCR test also becomes a negative when it increases the time, and antibody level is increased. That means antigen level is decreased in the body. And for this, what we do is, first of all, we need to do the DNA extraction by using the any of the standard DNA extraction kit. Then we can perform the real-time qPCR for Orencia Susugamusi. That is here given the example of 16S rDNA gene target, which is targeted for this qPCR, and primers and probes which were used were the forward probe, then reverse and forward primers and probes as mentioned here. And then conventional PCR targeting the 56 kilodalton type specific antigen was performed by using the following primers: primer A and primer B. Then in case of the qPCR, we can directly observe the report result as positive or negative. And in case of the conventional PCR, we do the PCR, and then after that we do the Agaro Gel Electrophoresis. We take the PCR product from this Agaro Gel Electrophoresis, and then after we can send it for the DNA sequencing and the phylogenetic and other molecular studies. So this is the figure of this Agaro Gel Electrophoresis. Here we can see the sample is Nepal 1, Nepal 2, and then after Nepal 3, and then this is the 320 base pair. We compare with this, and also there is the positive control, and also there is the negative control, and then after samples. So this is the figure of Agaro Gel Electrophoresis. This Agaro Gel Electrophoresis might be used if we perform the phylogenetic study, if we only need to diagnose in the laboratory for the purpose of treating the patient, and that laboratory diagnosis is better to do the qPCR or real-time PCR. If we go for phylogenetic study or DNA sequencing, at that time only we use this Agaro Gel electrophoresis with the conventional PCR. And this DNA sequencing, the PCR product from the conventional PCR was used for DNA sequencing. The sequences obtained were identified with comparison with the sequences available in the gene bank using the blast technique in the NCBI website. Then phylogenetic tree, phylogenetic and molecular evolutionary analysis were conducted by using the MEGA7, that is molecular evolutionary genetic analysis software. And this is the example. This is the DNA sequences of the DNA. These sequences were performed by the Macrogen, South Korea. And we can see here the 56 kilodalton gene and their sequencing, and also there is shown the base pairs present in the DNA. And this is the phylogenetic analysis, phylogenetic study. And after the DNA sequencing, we compare the sequence with those sequences which are already deposited in the gene bank in the NCBI website. And while comparing with these sequences which were obtained from our country Nepal. Here in figure we can just see there is Nepal 1, Nepal 2 and Nepal 3, and this Nepal 1, this Nepal one closely related with the Orencia Susugamusi strain TW73R, that is from Taiwan, and this GDYS21G from the China, and also this Orencia Susugamusi strain LA1 from the Thailand. So what we can say is these are those serotype strains which are present in our country. They are more or less similar with the carp-like serotype strain which were diagnosed or which were identified from the Taiwan, China and Thailand. So in the present study, serotype strain based on the 56 kilodalton gene showed that study isolate were of carp-like serotype strain. The cap is the most common serotype strain, accounting for approximately 40% of all isolates, and these are more prevalent worldwide, reported by the serologic testing and genotyping in Southeast Asia, Vietnam, Thailand, Philippines, Malaysia, and Cambodia. Also, they are seen in the southern China, Oceania, Japan, Mongolia, Taiwan, and Australia. And these strains are also cited as the most common circulating strains in other Southeast Asian countries like India, Pakistan, and in Japan. And next, the isolation also can be done by culture. However, this culture of those bacteria is not possible in the ordinary culture media. So these Orencia and then after Rickettsia and Chlamydia, they are for their culture. We can use the cell culture technique, or we can use the egg inoculation technique. So here these organisms can be isolated from the guinea pigs or mice, and sometimes from the yolk sac of the chick embryo, varicose lines, or the medical research MRC5 cell line from the patient in early phases of the disease. The most important thing is their diagnosis, or for their culture we require the biosafety level 3 laboratory, and we need to follow the strict biosafety precaution. And these Orencia may grow during 3 to 5 days on a Vero cell line and MRC5 cell lines, and when their growth can be identified by the immunofluorescence using the group and strain specific monoclonal antibodies. And also for this actually this culture and animal inoculation culture, the next thing what I want to say is when we take the antigens for the diagnosis, when we do immunofluorescence assay or when we do ELISA, we require the antigen. And some in the ELISA antigen sometimes they use the recombinant antigen, otherwise they use for the immunofluorescence they use the antigens which are derived from the culture, culture of the organism. So culture is also equally important in those places where there is ongoing research of these Orencia, or when there is diagnosis of these Orencia by using immunofluorescence assay. And next, animal inoculation. This has been widely used in the past, but they are now being replaced by the cell culture systems. The mouse is the species of choice for the isolation of Orencia susugamusi. Blood clot ground in skim milled or any suitable medium are inoculated intraperitoneally, then these animals have to be observed for 3 to 4 weeks and spared from the peritoneum, tunica, and spleen of the animal stained by Zimsa or Jimenez stain. They demonstrate the rickettsia. And cell culture, it is most widely used method for isolating rickettsia from the clinical samples. Then we can use the Barrow cell lines, and then after MRC5 cells, which might be used frequently, and also sometimes there might be used the mouse fibroblast cell monolayer, and which can be used for the culture in a suitable media. Uh, and next, what we need to do is the differential diagnosis. For the differential diagnosis, we need to find out the uh, other acute febrile infectious condition, such as there might be difficult to diagnose from the typhoid fever before the diagnosis of scrub typhus. What they used to say, this scrub typhus acute febrile illness is the typhoid fever, because there was no differential diagnosis, there was no diagnosis by this ELISA and immunofluorescence technique, and so they used to say it as a typhoid fever. And it is also, we do need to identify, or we need to do differential diagnosis with the dengue, we need to do differential diagnosis with the leptospirosis and other, and also other causes of the acute febrile infectious illness. And treatment and prevention of the scrub typhus. Scrub typhus responds more rapidly to antibiotics than any other febrile tropical febrile condition. Patients generally become febrile within 24 to 36 hours after initiation of specific anti-rickettsial therapy. And dramatic recovery to doxycycline or chloramphenicol therapy is characteristic in scrub typhus. So post-rickettsial treatment, if the fever is not subside within 48 hours, then it is unlikely the patient is suffering from the scrub typhus. The most important thing is the treatment, and treatment can be done very easily by taking the doxycycline 100 mg twice daily, or oral tetracycline 500 mg 4 times daily for 7 days. So initial treatment, initially initially chloramphenicol therapy was very useful, but now doxycycline treatment is very useful. So this is the bacterial infection which can be easily treated. So now the clinician also, they should consider the diagnosis of scrub typhus when the patient is present with the acute febrile infectious condition into the clinic or the hospital or any other healthcare settings. And these are the references, and these are the further reading which are which two papers which I have published. You can just go through it and then after see. If any queries, let me know. Otherwise, during this COVID pandemic, maintain the social distance, take care, stay safe. Thank you.
Yes.
Okay.
Thank you all
Thank you very much
for
for the
being
wonderful
patient
seminar, sir.
and listening
Thank
to
you, sir.
my lecture.
Thank you, sir. Thank you, sir.
So it was a wonderful seminar, and you covered everything regarding this scrub typhus, sir. So some queries are there. First question is whether the scrub typhus will transmit from pregnant woman to the fetus, to the baby. Can it transmit?
Thank you all.
Yes, sir. Sir, there is a question from students, sir. Oh. Sir, am I audible? Hello, sir. Muskan, please continue with vote of thanks.
Okay, sir. Am I audible?
Yes, you are audible.
Yes.
Yes, sir. Gratitude is not only the grateful of the virtues, but the parent of all the others. Let us be grateful to you, sir, who gave us very important and meaningful knowledge with us. So I would like to thank you on the behalf of all the 3 semesters and all the faculties. I may like to express our sincere thanks to
Thank you so much. Actually, here is
Yes, sir.
my audio. So I'm just saying you have a good day. Take
Yes, sir.
care, and we'll see you soon.
Sir, am I audible, sir? I think sir has some network issues there.
Yes, sir.
Okay, Muskan, please turn on your camera and finish with vote of thanks.
Okay, sir.
Yes.
Yes, sir. So I
Yes.
may like to express a sincere thanks to Sir for giving us excellent coverage to the different topic and the important topic. Finally, I would like to take this opportunity to place and record our hearty thanks to all the faculty members, our beloved deputy sir, and our respected dean sir for giving us precious time of theirs. And thanks to all the semesters, first, second, third semester students for indulging in this webinar and giving their vote to make this seminar successful. Thank you all for their presence.
Okay. Thank you
Yes,
very much, Muskan. So
yes, sir.
thank you one and all for making this event a grand successful. So I would like to thank Ms. Muskan for hosting the event, and my special thanks to all my dear students and my beloved faculty members of MLT. Thank you very much. So thank you.
Thank you, sir.
Yes.
Okay, there was one question that
Yes, sir.
during the pregnancy, can it transfer from mother to fetus? Actually, pregnancy, during the pregnancy, fetus is 100% protected, and there is no evidence of transmission of this disease from mother to fetus.
Okay. Thank you very much, sir.
Okay, thank you, sir. Thank you so much, sir.
Okay. I would like
Okay.